Hi, my name is Maitre Patel. I am a professor of radiology at the Mayo Clinic in Arizona. I'm also the inaugural program director for our radiology residency, and it's my pleasure to give you an overview of our program. The main purpose of this slide presentation is to enable you, the candidate for a residency program, a good understanding of how you might answer this question for yourself. Why Mayo, Arizona? First, a brief history of Mayo Clinic. Dr. William Mayo established his practice in Rochester, Minnesota in 1864. He had traveled there during the Civil War to examine Union forces, and that was his job. And after the war was over, he stayed on and created a practice that was joined by his two sons, Will and Charlie. The term Mayo Clinic didn't really get formally established until 1914, referring to the educational program that they pioneered. The clinic decided to expand in the early 1980s, opening a facility in Jackson, Florida in 1986, and our facility in 1987. Collectively, we all operate under one organizational umbrella, known as the Mayo Clinic. Our practice in Arizona has exploded since inception. You can see that we originally had just 2 radiologists and then 3 in 1987, which expanded to 17 a decade later, and then another decade after that up to 43. And in fact, this is a constantly moving number. Currently we have nearly 50 radiologists on staff. What I'd like to do in this presentation is to give you some understanding of what we think underpins our excellence here at Mayo Clinic, Arizona. And the 3 main pillars of that excellence are the tools that we use, the methods we employ, and the people who do the work. Without a doubt, cutting-edge tools support excellence, and we have these tools at our disposal. And so, as is shown in this cartoon, these tools enable us to get beautiful images. But these tools are not sufficient to create excellence. Having outstanding tools is critical to excellence, but it's not enough. As the cartoon at the bottom of this slide shows, radiology's product is more than just the image. A radiologist understands the components of the image, understands what's wrong, and can help fix those problems or direct someone else to address them. And the way we do that is to rely on a methodology that is very important to our success. Mayo Clinic has become famous because we rely on these 4 things. We rely on subspecialization. We are fully a collaborative organization. We have a strong emphasis on clinical research, and we highly value the importance of education. If you went to a dinner party and discussed medicine with people who were not physicians, they wouldn't be surprised to know that there are different types of internists. They know that a gastroenterologist is different than a rheumatologist or an endocrinologist. Similarly, they know that there are different types of surgeons. A urologist treats different sorts of conditions than a colorectal surgeon. But most lay people don't realize that radiology is similarly highly subspecialized. And in the 21st century, it's not enough to talk about just being a radiologist. For many people, radiology implies a subspecialty focus, and this is no different at Mayo Clinic, Arizona, where we are subspecialized. These are the 8 divisions at Mayo Clinic, Arizona, and at first glance you might look at this and say, well, this doesn't really look any different than any other academic organization that chooses to have subspecialty divisions within the department. And while that may be true, I'm going to show you in the next few slides how things are actually a little bit different at the structural level. And clearly, there's plenty of evidence to suggest that subspecialization improves care. This is just one study that I've shown on the slide. and there's no point in going through it in detail. But it essentially indicates that radiologists who are subspecialized can direct proper care of different conditions better than individuals who are not subspecialized. So what I'd like to do is to put that in the context of just one procedure that we do here at Mayo Clinic and that lots of radiology departments do, to try to illustrate maybe some of the differences that you might find in our organization as compared to others. Let's take a look at renal transplant biopsies. Now, when you do a renal transplant biopsy, you want to get the glomerular tissue, and there are pathologic standards that exist for what defines a successful biopsy in the literature. The literature had suggested that the types of samples that pathologists were getting were mostly successful, but not always successful. And in papers that had been reported, generally pathology departments were getting about a 55 to 85% success rate in terms of getting the types of glomerular standards that they wanted. And the people who were getting these samples were using 14 to 18 gauge needles and oftentimes getting more than 2 samples. Because we have a subspecialty approach at Mayo, only the radiologists in the ultrasound division do these biopsies. And so over the years, having concentrated the expertise into a few people's hands, we realized that the best way to do these biopsies was to use a cortical tangential approach, which is illustrated by the image on your left, showing an ultrasound where the needle, which is highlighted by the white arrows, comes in and skims the surface of the kidney or the outer cortex of the kidney. And that's different than the approach that many people were taking elsewhere. And we were therefore able to limit the number of samples we needed to take to as few as possible and limit the number of complications. We published this approach almost a decade ago, and it has become the de facto standard of care in how individuals pursue renal transplant biopsies. And so from that perspective, it's a great story about how specialization within radiology can help lead to better outcomes. But what's even more important is to understand why this was possible at Mayo Clinic, Arizona, and was not possible at other places. And the reason for that is to understand that renal transplant biopsies at most institutions are heavily done by transplant nephrologists, not by radiologists, even if the radiology department is involved in the imaging and the localization for those biopsies. In other words, at many institutions, transplant nephrologists who do not routinely do ultrasound-guided biopsies will do these biopsies because there is an RVU attached to that work effort. Because at Mayo we are a multi-specialty group, and because we strongly believe in subspecialization, the key to the story is that our patients get better care and we can come up with novel approaches because the people who are most experienced with the technique get to do the biopsy because we don't care where the RVU revenue falls to. At Mayo Clinic, I get paid a salary, and so do my transplant nephrology colleagues. And so they allow us in radiology to do the biopsies because there's no incentive for them to do the biopsy from the perspective of getting the revenue. And they understand that the biopsies are best done by people who do biopsies all the time. Of course, we're going to train their trainees in understanding how to do these biopsies so that when they go out into practice, if they need to do them, they can do them. But here at Mayo Clinic, Arizona, as a trainee, you'll be involved in the things that radiologists do best because the organization is set up in a subspecialized way so that there are less turf battles between different departments for those RVUs. Indeed, that's the main take-home point of why I wanted to go into this story about renal transplant biopsies. You, as a radiology resident, will benefit from the subspecialty approach that we have at Mayo Clinic. That commitment to subspecialization extends to other areas which will benefit you as a trainee. For example, at Mayo Clinic, Arizona, when you're on call, you'll be independently looking at films and imaging studies overnight and in the evenings and on the weekends. And those studies will get reviewed by faculty, but they'll be reviewed by subspecialty faculty to the extent that when you're on call at night, you actually have 6 faculty members on call with you. There's an ultrasound radiologist, there's an abdominal radiologist, there's a neuroradiologist, there's a nuclear radiologist, there's an MSK radiologist, and there's a cardiothoracic radiologist, not to mention an interventional radiologist who takes separate call. And so as a result, when you interpret a brain CT on call, the feedback that you get about that study and your report will come from a neuroradiologist. When you interpret a rule-out appendicitis CT on call, the feedback you get will be from an abdominal radiologist. When you interpret a rule-out ectopic pregnancy study on call, the feedback you get and the teaching you get will come from an ultrasound radiologist. And that sort of subspecialization is going to impact your quality of teaching. There can be no doubt, and the literature now shows, that the degree of subspecialization of your coaches, of the person who's going to read out your films with you, is very important in terms of the quality of the teaching that you get. This is a simple premise that is readily apparent from everyday life. When you play high school football, your coach may be a player who played a particular position who's reasonably well qualified to coach you as a quarterback or coach you as a defensive lineman or to coach you as a safety. However, when you're in the big leagues, when you're in the professionals, the quarterback's coach is somebody who has expertise in quarterbacking. The linebacker's coach is somebody who has expertise in being a linebacker. And the defensive backfield coach is somebody who has expertise in playing those positions. And you can bet that the quality of the play of the person who's getting coached depends a lot on the person who's coaching them. And this is an important point for you to remember. Let's turn our attention to a second piece of what makes Mayo special, and that's our emphasis on collaboration. There's definitely evidence to suggest that when the radiologist is part of the team in the huddle making the decisions, that those decisions are better. And this is just one article that's listed here that gives some evidence to that regard. At Mayo Clinic, Arizona, we're firmly committed to collaboration, and we use lots of tools to achieve that. We have a very robust electronic medical record. We rely on clinical care conferences where we meet with our colleagues, and we do cross-campus collaborations. So, for example, the ultrasound division at Mayo Clinic, Arizona will have quarterly meetings with the leaders of the ultrasound divisions at Mayo Clinic, Rochester, and Mayo Clinic, Florida, to understand best practices. This also extends to education, where we have bi-monthly meetings as educators amongst the 3 sites. And so we discuss the best tools and methods to prepare residents for success. Collaboration is a primary value at Mayo Clinic. It's embedded in the structure of our organization. For example, we all get a salary, and so there's no economic incentive for us to cherry-pick RVUs from other departments. As a result, there is a diminishment of turf battles. It allows the organization to set up the practice in the way that's best for the patient, and the renal transplant biopsy is one example. This also enhances the experience of our trainees because our clinical colleagues are invested in your success as a radiology resident, and so they don't see you as a threat. In fact, they will be welcoming to you when you come onto their service if you need to, such as occurs for some of our residents who choose to do advanced electives in breast, for example, who then rotate with our breast surgeons in breast clinic, and, for example, with our IR-bound residents who choose to work with our vascular surgeons and with our intensivists for different rotations. And so the clinical colleagues at Mayo outside of radiology are invested in the success of the radiology residents because we believe in collaboration. Turning our attention to research, which is another piece of the special sauce, another ingredient in the special sauce. Clearly, research is an important endeavor at Mayo Clinic in Arizona. We have an active translational research lab headed by Dr. Oglu, who's received over $1 million in grant funding. But many of our faculty are doing research in areas such as imaging patterns and techniques, safety and quality, informatics, and researching education. And this intellectual curiosity and research extends to our residents who are involved with us in doing that research. This is just a table showing, as of last year's graduation, how many projects our residents were involved with for the preceding 4 years. And if you look at it, you can see that there were over 100 either journal manuscripts or national or regional presentations that were performed or spearheaded by our residents. And so the average graduating resident in our department has been supported to attend 10 trips during their 4-year residency. And finally, of course, education is a very important ingredient of the special sauce at Mayo. It's a critical role in making us as good as we can be, because we understand that nothing promotes excellence as much as teaching. It improves our performance and it helps us to develop best practices. We're definitely committed to education at Mayo Clinic in Arizona. Obviously, we have a residency program to which you're applying. We have fellowship programs, 6 a year at this point. And our faculty are very involved in CME courses, and so we are heavily involved in educating radiologists out in practice. Beyond our formal education programs and the CME courses that our faculty are involved with, they also are involved in publishing books. They're involved in teaching our allied health staff and other physicians. They contribute to the literature, and clearly clinical education is rampant in our conferences, our rotating trainees, and the daily work that we do. At Mayo, Arizona, we've been involved in education for over 2 decades. Our first residency class was in 2014, but the planning for that class started almost 10 years prior to that. And in fact, in 1998 is when we started planning our entire fellowship and residency program. In 2000, we had our first fellow and built that fellowship so that by 2008, we had 5 fellows a year. And that's when we started planning the residency program. And the reason it took us some time to do this is because we wanted to get the right people in place. In 1998, we only had 17 radiologists. Now we have nearly 50. And what we've been able to do in that ensuing 2 decades is to get the right educators so that we can provide first-class training in all areas of radiology, which we felt we could do by the time 2010 started. And so, in 2014, we did get our first residency class, and by that time, we had a fellowship that had grown to 9 per year, and we really didn't have any problems getting fellows because of the quality of our education program. And so what we've done is balance our training so that we have both residents and fellows. And you can see in 2014, we started with just 2 residents in that first class, the half class essentially, and we had 9 fellows a year. And over the ensuing few years, we built up the number of residents we have, such that now we are at an equilibrium of 16 diagnostic radiology residents, 4 per year. And we had decreased the number of fellows that we have, and now are at an equilibrium of 6 fellows a year. So we have a total of 22 diagnostic radiology residents and fellows. But we've also started an independent radiology residency program, an independent interventional radiology residency program with 2 individuals a year. So we have a total of 24 trainees in our department at this time. And there are plans to make that bigger over the ensuing few years as we grow, so that we will grow our residency to hopefully eventually have 6 residents per year. Again, that's not the current paradigm, but it's the paradigm that we hope to achieve in the future. And so if we expand out our timeline, you can see that our first two interventional radiology residents will start in July 2020. They successfully matched last year. So from our perspective, we think that the independent IR residency pathway that we've chosen is the most flexible pathway for our residents. It allows up to 2 individuals in our DR class to proceed and complete their IR training within the same amount of time as if they had started in an integrated IR residency. Because 50% of our class can do ESIR, that is actually more than any other program in the country. The beauty of the system that we've developed, however, is that it also allows for our residents to consider rounding out their IR experience for that final year of training by going to another institution if they so choose. We will prioritize internal successful candidates, but we'll also help them get alternative training if that's what they choose to do. And in fact, in the 2019 match, 3 of our residents who had completed ESIR, who we would have been happy to have completed their IR training with us, chose to round out their experience by going to other places to find training experiences that complement the training experience that they got in our program. And so of those 3 residents, 1 is going to Mayo Jacksonville for their final year of IR training, the other is going to NYU, and the third is going to Emory. All 3 are excellent residents, would have been great to have with us, and I think would have been happy to do their IR training with us, but this gives them an opportunity to network with other IR physicians at that final year of training and to see how other people do things so that they can really build their repertoire. There are many important features of the curriculum which I'd like to highlight. First, most of your rotations will be either at the Mayo Clinic building, which is shown in this picture, our outpatient facility in Scottsdale, or the Mayo Clinic Hospital, where we do the bulk of our work, and that's in Phoenix. Our facilities are highly ranked, as manifest by high honors in many U.S. News rankings that have come out. We go out of our way to make sure that you get all the training you need. So we have a built-in trauma rotation for all of our residents to do in their second year at St. Joseph's Hospital. All of our residents get extensive pediatrics rotations at Phoenix Children's Hospital. In fact, you'll go there once a year for the first 3 years, and you're eligible to do subspecialty experiences there in your 4th year. And our residents who choose to get OB training beyond the first trimester stuff that we do here at Mayo can do so by pursuing elective at Valley Perinatal. These locations that you'll be doing electives and required rotations at are not far away from where people choose to live. This is an aerial map of Phoenix showing the hospital at the top off of the US 101. Down at the bottom left, you can see that's Phoenix Children's near Highway 51, and then the 2 points on the right, the one farthest to the right is the outpatient building in Scottsdale, and the one closer to 101 is Valley Perinatal. These facilities are readily accessible by highway and by roads, such that most residents do not find commuting to be an issue. A few words about Phoenix Children's. It's an excellent partner for us, for our residents. They have a large pediatric radiology department. They have their own fellowship positions in pediatric radiology and its subspecialties, should you choose to subspecialize in those areas. And the residents uniformly have an excellent experience. In fact, Mayo Clinic Rochester in Minnesota currently sends a resident to Phoenix Children's Hospital for a rotation because of the quality of the experience that residents get at Phoenix Children's. We have a comprehensive core curriculum for you as a resident. This is a schematic of our conference schedule. We have a noon conference Monday through Friday, and we have 2 afternoon conferences, one on Wednesday and one on Thursday. This allows our divisions to have consistent exposure to our residents to go through a core curriculum. It also means that we don't have an early morning conference that enables you to start your rotation at the time that's most appropriate for that rotation. In some cases, there will be a conference in the morning that's division specific, that's usually aligned with clinical care teams to go over cases. We also are able to rely heavily on electronic methods of storage of our comprehensive core curriculum that assist our residents to get the information when it best suits them. We record all of our lectures, but we also record all the resident lectures at Mayo Clinic in Rochester and at our sister facility at Mayo Clinic in Florida. And as a result, our residents have exposure to teachers from all 3 organizations, as well as visiting professors who may have come to all 3 organizations. This video shows you how easy it is to get those recorded content. If you go into the intranet, you hit the video tab and go to programs, you can easily find where we house all the radiology content for residents. You can see here we have Arizona, Florida, and Rochester, and within each we've subdivided them into different divisions. And so, for example, if you wanted to see a particular lecture from the abdominal division at Rochester, you could click on the repository for abdomen. All of the most recent ones that have been recorded will come up. Here's one such lecture given by the world-famous Dr. Heiken, who is a professor of radiology at Rochester, and you as a resident in Arizona can benefit from Dr. Heiken's experience by watching his lecture. One of the unique features of our curriculum is that we integrate residents into operational teams, and so during your R3 year you will have the opportunity to work with a team that oversees one aspect of our radiology operations, and you'll meet with that team on a monthly basis along with other team members. This is easier to understand if I put it into the context of one particular team. So again, since I do ultrasound, let's take the ultrasound team. The ultrasound operations team consists of physician leaders in the practice, along with sonographers who are the leaders, the team lead, the manager. We also have nursing leaders in that operations team. We have accountants. And so these team members will meet on a monthly basis to review our finances with respect to our operations on ultrasound. Are we making money or not making money? Are we billing appropriately? What's our billing capture rate? Do we have to hire more sonographers? Do we need to find new spaces to do ultrasound? Do we need to buy new equipment? These are the kinds of questions that the team will look at along with other aspects of the delivery of ultrasound within our department to our patients. And as a resident team member, you will work with these people and have access to the data that they're seeing, to the decisions that they're making for that whole year. This will give you some insight into how the business of radiology works, and it allows you to understand the kinds of things that you'll need to know regardless of whether you go into a private practice setting or an academic setting in order to have good fiscal stewardship of your practice. We ensure that our residents have all the tools and resources they need for success. There are a variety of tools and resources we provide to our residents. When you start, we give you an iPad that has content so that we have a subscription for you to Rad Primer, to StatDX, to Kevlar. You can see recorded conferences as I've shown you. We pay for your month-long experience at the AIRP. We pay for an attendance meeting during your 4 years, so you can go to a conference without having to do any research or any sort of activity to gain admission to that conference. Those can be anywhere in the world. We've had residents go to a variety of different places, including Paris, for these attendance meetings. We will fund your presentation meetings. As I mentioned before, our residents are involved in research, and when you are involved in a project that's getting presented, you're eligible to go, and we'll pay for your presentation of that data at the meeting. So our our residents have to date, by graduation, gone to an average so far of 10 conferences per resident during their residency. Of course, you don't have to if you're not interested, but many of our residents are. We give you web access to all sorts of journals and lectures. Our library of resources is extensive. We pay for your ABR fees, and we have a meal allowance, and so you get approximately $1,250 a year for meal allowances with regard to your conferences. Another important feature of the curriculum is our commitment to making investments in informatics and giving you access to data that will help you. We have very effective data mining software in our department using Illuminate, where you can find interesting cases. This helps you do your research. It also helps you find clinical material to augment your learning. The last thing you want to do when you go to a residency is be really busy but not have seen 50% of the things that you need to see. And so what we are able to do at Mayo is to keep you very busy and engaged, but because we have so many cases in our data bank, you can actually augment your learning so that if a faculty member is teaching you something about, for example, glioblastoma, and you are looking at a case of a patient with glioblastoma, that faculty member or you can go to our software and you can find other patients who have glioblastomas or other types of brain neoplasms that might be in the differential diagnosis to see what those look like, and not just one or two images, but the entire data set. We're committed to giving you the information you need about your own practice, and so we routinely give you access to the quantity and the types of cases that you do. So when you come for an interview with us, we'll be happy to show you how our residents have access to this data for themselves. Indeed, one of the important features of the curriculum is that there is a very high volume of experience for you during your residency, including procedural experiences. We've taken care to have a very organized approach with your curriculum, and so we've been able to essentially give you 1 year of elective time during your 4-year residency. This allows you to focus your advanced training in those areas that are of most interest to you for your future employment. If you come for an interview, I'll be happy to go through our curriculum with you in more detail, but this is an overview of your 4th year, for example, where the only 2 required rotations are a 4-week experience in breast imaging and a 4-week experience in interventional ultrasound. Other than that, you're able to tailor your curriculum in your 4th year to target those advanced topics that may be of most interest to you. One of the things that you may choose to do during your 4th year is to engage in the Mayo International Health Program. So this is a fantastic program at Mayo Clinic that pays residents to do global outreach, to have new experiences in underdeveloped areas in radiology. For example, one of the rotations we have set up as a routine thing is a volunteer experience in Cambodia with a hospital there that we have affiliated with and to who we have sent radiology trainees before. But your experiences don't have to be at that hospital. They can be anywhere in the world that we can set up with you that is underserved that would meet the qualifications for the Mayo International Health Program. For example, one of our residents who graduated in 2019, Dr. Chris Saplicki, chose to go to Nepal for 4 weeks and work at a facility there, and combine that with a 2-week subsequent vacation in which he was able to climb the Himalayas. There are other out-of-the-box experiences that you can have during your 4th year in our program. One of our residents, actually 2 of our residents now, have served as instructors in gross anatomy at our medical school during their 4th year for varying periods of time. One resident focused on neuroradiology and spent 2 weeks in the neuroanatomy block for gross anatomy, while the other resident, Dr. Smith, who had previously taught gross anatomy prior to being a radiology resident, actually spent 8 weeks during the entire gross anatomy curriculum for our medical students and taught gross anatomy. As I mentioned earlier, there are robust IR options within our program. We'd be happy to go over our block diagram for the early specialization in IR program that we have, in which you essentially do quite a bit of IR during your 4th year to enable you to finish your IR residency in just 1 additional year of training. As I mentioned before, this enables up to half of the class to do ESIR and finish on time if that's what they want to do. But we don't require that any of our residents in any class do IR if they don't want to. I mean, to do advanced training in IR. All residents will do at least 3 months of IR as part of their basic radiology training. This ability to allow up to half the class to do ESIR is more flexible than any other program. We are committed to independent call experiences for our residents, but we are also mindful that call is an opportunity for you to learn when you are best prepared to handle call. And so we have a purposeful call strategy. We don't inundate you with all of your call during your 2nd year of training. Instead, we have a strategic approach to how we give you these independent experiences that builds on the fact that you get better and better as you get further along in the residency. All of the call that you will take is just at one facility, our Mayo Clinic Hospital, and so this is the call schedule, the call distribution, and I'll be happy to go over this with you during your interview. Suffice it to say that we have made it so that call is fairly evenly distributed amongst our residents and our fellows, and this enables us to create call pairings and experiences that are well tailored for your level of experience. So for example, you can see that our R2s take Saturday and Sunday day call when they are partnered with a more senior fellow, and in that way they're able to get the most out of their call experience, because there's always somebody there who can help them with anything more difficult. It also allows our fellows then to participate in our teaching program. The overnight week calls through night float are distributed during your R3 and your R4 year. We're very proud of the program we've been able to build. It's very important for you to recognize that we are a nationally recognized program. This is just one example of that. Currently, the antmini.com website lists all of the semifinal candidates for best program in diagnostic radiology training, and you can see at the map on the bottom left of this slide that there are 6 programs west of Mayo Clinic Rochester that have made the list. And so we think that all those other programs are also quite good, but we're in that league with UCSF, with UCLA, with the University of Washington. That's the level of training that you get at Mayo Clinic in Arizona. So I've spent a lot of time talking about our methods. We didn't spend much time about the tools. Be happy to show you those tools when you come. But those tools, though very important, are not sufficient for creating excellence in a department. But by far and away the most important thing that creates excellence in a department, and this is true for our department, are the people who are doing the work. It's really not possible for me in this short video to go through the accolades and expertise of all of the people that you'll be working with here at Mayo. I would like to highlight a few things. All of our faculty members are fellowship trained and they're subspecialty oriented. They all have multiple connections to other centers, both academic and private groups, and not just local practice groups, but groups in other states as well, because we have a variety of faculty from all over the country. These faculty members are highly experienced in training education. They include many former program directors or associate program directors at fantastic training programs such as UCSF, Mallinckrodt, University of Illinois at Chicago, and Pittsburgh. And so, as a result, our faculty have decades of experience with trainees. So we started this long video with a question that I wanted you to try to be able to answer for yourself. Why Mayo, Arizona? And with apologies to David Letterman, I'd like to give you the top 10 reasons, but these are not given in any particular order, and they are not intended to be humorous in any way. One thing you'll find if you come interview with us is that Phoenix and Scottsdale are excellent places to live. This metropolitan area is the 6th largest in the United States. It's a very easy and active lifestyle. It's a destination lifestyle for many people. It has a metropolitan atmosphere, and so there are job opportunities for significant others, and it's a growing area. As I mentioned, our environment is one of high quality collaboration with our partners in other disciplines, and this means that we have absence of many of the interdepartmental politics that are so common in other centers. That, along with the fact that we're top ranked, means that you'll be practicing at the state of the art. We are fully committed to a subspecialized process. We do not believe in a general radiology readout. You'll have 6 different faculty members on call with you every night, giving you feedback on your cases. I've tried to show you how we're organized and purposeful with the way we do things. We have a strategy, and we do seek objective measures of performance, and we share those measures with you in both in terms of our financial performance as well as our productivity performance as you sit with us on operational groups. This will help you learn the business of radiology. We have an abundance of pathology, and it's found in our patients, not in our staff or our colleagues. And we have search tools that will enable you to find those cases to augment your clinical experience as well as to serve for research projects and other reasons to find different types of interesting cases. And finally, we have a high procedural volume for the residents, and they are very well trained in terms of reviewing cases quickly as well as doing procedures quickly. Without a doubt, Mayo Clinic comes with a brand that gives you instant credibility as a graduate from our program. You'll be a member of the Mayo alumni, and you'll be proud of the fact that you were able to train at a nationally ranked facility. We're committed to your success. We'll give you the support and the resources you need because we're not going to let you fail. Our brand demands that we do things high-end, and so you'll have access to resources that exist across our enterprise. These tools will enable you to succeed and really have your best interest in mind. Our practice is growing, and this is important to consider as you consider future opportunities for employment. As we get bigger, we're going to need people who are well trained to help us deliver the best care to our patients. And so, having trained at Mayo, you'll be in the driver's seat for consideration for those opportunities. We've grown from 2 radiologists in 1988 to nearly 50 today, and we're continuing to grow. Now that our base of established educators is in place, we're going to be looking to hire the best of our own who choose to pursue academic careers. But even if you decide not to come here, we have a well-connected faculty to help you take the next step in your training or in your practice. One of the best things about being a resident at Mayo is your ability to interface with very experienced faculty who are well-versed in working with and developing trainees. Many of these individuals, as I've tried to show, were leaders in other well-known academic organizations or have grown up in the Mayo system and are fantastic educators. And finally, the 4th year is an elective year, so it allows you to tailor the curriculum to your particular interests. If you want to pursue IR, you can do ESIR. If you want to do international opportunities, we can help fund you to get there. If you'd like to do more research to build your academic portfolio, we can give you research time. And there are abundant other opportunities, including chances to teach. This allows you to develop a solid foundation for any career. So while we started with the question, why Mayo, Arizona, I hope what you really have now is an epiphany. Why, of course, Mayo, Arizona. There are multiple reasons why this training program is one of the best training programs in the country. With that, I want to thank you for your attention during this presentation. I hope it has strengthened your interest in pursuing diagnostic radiology training at Mayo Clinic, Arizona, and I wish you the best of luck in your search for the best training program for you.